group here. Good evening, everyone. Can you all hear me well? I hope. And I'm Dr. Ravi Kohli. I'm the Secretary of RP currently, and I'm also a psychiatrist in Pittsburgh for 28 years. And we have a distinguished panel of psychiatrists in various phases of their careers and various segments of practice. And like I was telling earlier, we have a very distinguished panel besides myself, which I'm not the most distinguished guy here. And we've gathered all this group of people in just less than 24 hours. We planned it yesterday and we are executing it today. And I'm really excited to offer all of their expertise to you. I also want to kind of be thoughtful and prayerful about all our colleagues that are battling this crisis, this COVID situation. And let's have a half a minute of silent prayers for their well-being and their recovery, as well as to strengthen their families' spirits while we're going through this. Just half a minute of silent prayers would probably do some wonders. Okay, thank you. Thank you for all of you for joining this evening. I will introduce the panel here in no particular order. I'm just reading from the flyer. My good friend, Dr. Tarak Vasavada, is in Huntsville, Alabama. He's a clinical professor of psychiatry at University of Alabama School of Medicine. And he will talk about ethics and other aspects of care during this time of resource allocation and resource scarcity. And then we have Dr. Rohit Chandra. He's from Boston Medical graduate, and he's an instructor at Harvard Medical School. And also he's a child and adolescent psychiatrist at Mass General Hospital. He's also a very good speaker and well-known in New England area. And then we have Dr. Murali Rao, professor of psychiatry in Loyola University School of Medicine. He's also chairperson, a department of psychiatry, department chairperson in Loyola University in Chicago. And then we have our second generation young psychiatrist, very dynamic psychiatrist in private practice, Dr. Mona Gupta. She also gracefully accepted our invitation to join the panel in a short notice. She's in private practice in Raleigh, North Carolina. She has a very well diversified practice, and she will talk about substance abuse. Rohit will talk about emotional reactions and how it's impacting child psychiatry. And Dr. Murali Rao will talk about various resources he has compiled, as well as his experience of practicing consultation psychiatry in general hospitals, now especially in this COVID situation. I'm a psychiatrist in Pittsburgh area. I'm a medical director for a community mental health clinic. We have multiple locations in 6 counties, about 12 locations. We serve about 60,000 clients. We have a huge number of staff. And we also ramped up very quickly to serve all our population in rural areas. So this is the panel. And each speaker will speak for 5 minutes. And then after we finish, all the 5 of us, we will have questions and answers session. And so we'll go with Dr. Vasavada. He will talk about, he will share his experience and as well as his expertise in psychiatry.
Okay.
Go ahead.
Well, thank you for giving me an opportunity to do this. Let me just start from the basics, sorry. I would really like to thank API and the leaders, and especially Ravi for taking this challenge to do this talk. We have focused, and I've attended some of these meetings, and they're scary like anything else what we've been going through here. I am, like Ravi said, I'm working in the hospital, and I was recently part of the committee of the resource allocation committee, and it made me think a lot about the time of this that we are going through. why is this so painful right now? Because, we are not who we are. We are scared. We are keeping a brave face. Imagine yourself like an 18-year-old drafted soldier in Vietnam who is going in without knowing where the bullet is going to come. Same way, some of these younger doctors, residents, nurses going in the room. We are called heroes, but we have doubts about ourselves. Hard to have routine. Some of the outpatient doctors, the routine is disrupted. Rapidly changing knowledge, you have to keep up. Loss of connections to what we had it. I don't go out anywhere, don't go eat with my friends. So again, finance is lost, uncertainty, fear of dying, and worse, giving it to our family or giving it to somebody else. Not being able to support our staff, we have to let go of some of our staff members. Lack of food and other household supplies, kids at home, working from the home. Medical practice has its own challenges. And so it is difficult to do all these things in a kind of making decisions in split seconds, being in the front line, feeling betrayed from the hospital's government when things are not available. And just that escalating waves of patients that never ends. At community level, we are all stressed. We cannot do things that we used to do. Community sense is gone. And national and state level, I won't go in detail, it goes a lot. Resiliency is something that I've been reading a lot. And it's something that is considered as a genetic trait or versus adaptive trait. But it is not just genetic because you can learn it and work on it before. It's bouncing back, hardiness, kind of demonstrating your elasticity. But the good definition comes that is capacity to spring back, rebound, and successfully adapt in a face of adversity. And there are 5 phases of resiliency in my book, and I'll talk about that in a minute. I would say that there are several elements of resiliency, but I put it this way, as is an active coping style. We'll talk about that in a minute. Preparing yourself, if you are really physically fit, mentally fit, you can do better, and to eat, rest, etc. Positive, your outlook, is it optimistic outlook versus hopeless outlook? A lot of people who survive thought that this is a temporary problem. They used the humor. They considered themselves not a victim when they came out. They used their creativity and games out of it to survive. And then gratitude was also a big part of it. Other bigger thing is moral compass or ethics that we have to follow. Our religion, spirituality, where we came from, what we learned from our parents, school, what is right, wrong, belief system. It's important that we keep those with us. Social support, can't speak anything more than that. We realize that. And cognitive flexibility. People who are rigid in this time will suffer. People who use the flexibility, ability to control their expectation and control their emotions will do better. So these are the domains of copying. Very quickly, I put the slides out there. You can read it. So there are 3 domains of copying that I always say. How you understand a situation. So basically, you understand the situation. If you don't understand, you cannot really work against it. So understand your stress and situation. And even the denial at some level is okay during this time. What one does about the problem, so there's the problem focus, how to solve the problems, and then how one controls the emotions. And like I said earlier, I put it like the key to resiliency is prepare, absorb the shock, recover from it, adapt, and then thrive. So there are 5 phases of this resiliency that has been documented in various organizational changes, but it applies to individual, family, workplace, etc. So going back to the ethics in time of COVID-19 is, I divided this is new concept, so I just was going through this. So pardon me if I don't include everything, because we can do whole day seminar on this, I think. Duty to care for doctors. So, and like I always tell my students, ethics are fluid. Today's ethics or today's right thing is tomorrow's jail, am I right? What you are doing today, somebody will see that you are hurting patients. So doctors are thinking, do I have to be there? Why should I expose myself? How can I reduce my exposure by not doing the procedures or doing telemedicine? In my case, like, do I have to round in COVID areas? Can I do it on phone? Is telemedicine a standard of care in acutely ill? And some of the doctors are trying to not to work because of their health or age, or they have sick family at home. I have a colleague that stopped coming to the hospital because he's taking care of his mother-in-law. He must be loving his mother-in-law a lot. Can I ask for time out during that time? Is it wrong to ask for extra protections? Now the organization is asking for extra life insurance, extra liability insurance, and even to ask the government to tone down people that will go after us. And then fighting against your employees in media. It's okay to fire your long-time employee in your office. Resource allocation, and this is the big one, discussed a lot. Who gets priority? First come, first serve, certain class or status, 30 years old, a mother of 2 versus 40-year-old doctor that has been working in a hospital. No comorbid conditions versus disability, somebody who has Alzheimer's, somebody who is mentally challenged. Do they get priority or not priority? Lottery system or based on predefined clinical criteria by blinded committee. And this is what we went by. There's a good articles on the resource. It was luckily written before by New York and Pittsburgh and other places, and we followed those. Once somebody is extubated, can we take them out of it? You know, can we call it a quit? And how long should we run the code? And this is the big one nowadays. How will my hospital allocate PPE and other resources? Should I call it a quit if things are not allocated? Should I walk out? You know, ethics of patient care is a big one. How can we maintain patients' right and confidentiality? How to work when family is not available or communicate with video chat? Following advanced directives, if patient have it, do we have it in front of us? Following their last wish, recording them on the last wish and broadcasting it. Are we breaking any HIPAA in that? Is it okay to do CPR or not to do CPR? What about CPR that comes in ER that are in accidents and others? You know, do we manage them? How do we ventilate them because they are not COVID patients? And patient confidentiality and duty to warn also. Patient's family is not there, so they are not fighting for patients, you know. Privileged class, some people feel privileged, especially healthcare workers that are prescribing preventive medications to themselves. Is it okay? Should someone hold supply PPE? Should I donate it if I have it? What if I need it? Who should get priority in testing, etc.? And who will pay for these things? Profiting in time of crisis. Some of the people that have made money made money during this crisis. Am I right? People have made money during world wars and during other pandemics. Hospitals have their own ethical dilemma. Leaders of the hospital, when to start and lift shelters in place for leaders. Hospitals is like all these dilemmas of procuring and allocating resources, taking care of your employees' well-beings, transparency without causing fears, and dealing with shady businesses, because I've heard a lot of hospitals losing money. They're getting supplies from China and places they never delivered. Dispose of waste and dead bodies. We've not even talked about it. How am I going to dispose this waste? Multiple hospitals. If you have multiple hospitals under your care, how are you going to take ventilators from one hospital and bring it to this hospital? And then firing and furloughing employees, creating a donation pool and managing money, creating a resilient society. FDA has their own ethical dilemma about relaxing rules and testing, bypassing animal models for vaccines, bringing out not so proven drugs out in the market, and relaxing liability rules. Medical organizations, should we have union? How to advocate, to be forceful with, without burning the bridges with our leaders. And residents and medical students. Can you believe it? Medical students are missing out on the once in 100 years of experience right now. And is it proper for them not to work?
Tarek.
Okay, that's fine. I'm done here. The last one was country, and there's ethics of that also. So thank you for, again, giving me opportunity. And I'll give it up to,
really
yeah.
Many questions that are,
sure.
Sometimes we don't think about it, but they're very relevant. For example, today only I was reading about CPR for patients who are being seen in the communities. Well, how do we handle those? How do we, what is essential, what is elective? Procedures, treatments, who do you hospitalize, who you don't? These are all ethical dilemmas, and I think Obviously, in an emergency situation, sometimes you don't prioritize ethics, but ethics are the fundamental um, practices that we have to always keep in mind. And of course, ethics are time-bound and contextual and sometimes change, but there are certain eternal things that we all have to follow, putting the patient's interest, community interest, public health interest. Like you said, a lot of treatments are being touted without much evidence, at least in a scientifically based treatments, but we can't say no to some of this treatment, unfortunately. But you hit a lot of points. Very good. Thank you so much. And shall I, Rohit, you want to go next? Are you
Sure.
ready?
Yep, sure. Let me. So thank you so much for having me. I'm Rohit Chandra. So I just wanted to highlight before we started on this that Dr. Kohli has put together a wonderful list of COVID-19 medical resources at ravikohlimd.com, I think. And Dr. Murali Rao has put together quite a stunning compendium of mental health resources, which you may be able to send to people, but there's a bit.ly link to them. And I've not seen better nationally than what Dr. Rao has put together, so quite wonderful. So I'll talk for 5 minutes. We have about 90 people on the call. This is really a wonderful showing. So what I'll touch base on is what we are going through at this time as people, both us and our patients, what to do about it, how to actually thrive, as Dr. Vasavada said, in the face of this. And then I'll touch on parents and kids and what we can say about child psychiatry at this time. So David Kessler, who worked with the late Elizabeth Kubler-Ross, talked about, has written articles about grief at this time, that people are going through grief. And Dr. Vasavada indicated that there's a lot of change that's happening. So change, loss, grief, however you want to frame it, our way of life has really changed. The past selves, the past lives that we knew, really have been turned upside down. The present is, full of constant change, and the future is uncertain. We don't know when this lockdown is going to be lifted. We don't know, when we're going to be able to resume the life we had, if it's going to be the same. So there's really been a lot of change. And along those lines, I think people are really cycling through a variety of emotions. So one is anxiety. So I just want to touch on a number of emotions. So one is anxiety. People's routines have been disrupted. And again, we're wondering what the future will hold. So anxiety is really quite prominent. Some people are sad. Everything has been canceled. My sister's wedding has been postponed. The family trip after that was canceled. There's just a lot of change that's happened, and that has led some people to be sad. And I should point out that people may be going through a variety of emotions, not just one. We're sad about the loss of lives of people we knew. We're sad about those who are in the ICU at this time. We hope that things will go well for them, but there's some sadness about that. There's really a lot of frustration about, what could have been, why are we not more prepared? So people are frustrated about a lot of things. Doctors are frustrated about going into the hospital without, proper PPE, or, with administrators, as Dr. Vasavada mentioned, who are kind of saying, go back to the front lines, it's your job. Doctors, of course, are altruistic, and do have a duty to care for patients, as Dr. Vasavada said, but we feel perhaps that in some cases we are being exploited or just expected to be altruistic. There's anger, as sort of mentioned, about how things could have gotten this way. There's confusion. So with all the changing medical information and kind of expectations of us at work, there's a fair amount of confusion. Some people are working too much at home, if they're working from home, and feel overwhelmed, or they're working too much at work and feel overwhelmed. If you're at home, you may be taking care of kids as well, homeschooling them, or just kind of monitoring their studies. You may be working near a spouse and going a little bit stir crazy. So some people are feeling overwhelmed. Others are feeling bored. There's not enough to do. What do I do with my time? I don't have enough to do. There's fear about loved ones getting sick, our parents, our siblings, our friends. And then there's some degree of hopelessness. This feels like it's not going to end anytime soon. And that, I think, has been really hard for a lot of people. So in terms of what to do, I think Dr. Vasavada touched on a number of things through his, his resilience portion. So in terms of active coping, I think maintaining a routine is very important. So getting up in the morning at a reasonable time, getting dressed like you would, making sure you shower if you're working from home, just making sure that you're kind of doing the things that you used to do and maintaining some degree of routine. And also if you have kids, trying to make sure that they are, in some sort of routine. It keeps that kind of structure, limits the anxiety. And I think, he mentioned social support in terms of resilience. That's obviously really important, reaching out to friends and loved ones. This is the time to connect with people you have not spoken to in a long time. We have Zoom, we have Skype, we have all sorts of video conferencing. There's really no excuse. We really should be talking to family members. My mother's side had a Zoom call on Sunday with 52 family members, including a 1-month-old baby. My father's side is, doing something this coming Sunday via Zoom. So, this is the time to really reach out to friends and family. Dr. Vasavada mentioned, physical exercise and rest. And I think exercise is a great point. I took a 1.5-hour walk with a friend between 5:20 and 7:20 today, just before this call started. It was wonderful. In terms of our immune systems, I think it's really important to keep our immune system strong. So sleep enough and at the right times. So try to sleep between maybe 10 and 11 at night, wake up between 6 and 7 in the morning, the normal times. You want to make sure your immune system is strong. As mentioned, eat well. So we have the opportunity to buy healthy food, cook healthy food, or get healthy takeout for that matter. So just try to make sure that you're eating high quality food. Not overeating if possible, although some people stress it. And drinking enough fluids. I have my chai in a giant mug. It's a ginger tea with spearmint, some cinnamon added. Interesting combination, but I enjoy it. So, and in general, I think just be kind to yourself, and that's a point I just wanted to really make one of the takeaways. But it's just be kind to yourself. This is self-care is so important at this time. We should not expect ourselves to be overly productive. We shouldn't expect ourselves to be perfect. If we are not achieving as much as we wanted to, that's okay. And be kind to others and give others a wider berth than you normally would. Everyone is under stress. So just really important to not be cruel to others, not be too angry at others, be good to your kids. They're often struggling with this. In terms of self-care toolkit, I think, different people manage their anxiety differently or manage their stress differently. So in terms of active coping, things that we can do are just to, use our senses, mindfulness kind of in a way. So with smell, some people cope better through smells. My father has created a disinfectant solution with some lilac oil. So not only can he control, sort of the disinfecting services, but he has, some really nice smells. When I was taking a walk, my friends and I smelled a couple of hyacinths and tulips, and I think there was one other flower, lily of the valley, I think. So that was really wonderful. That was sort of aromatherapy. Eat foods that you enjoy, drink the drinks like I have, that you enjoy. I also cope with visual beauty. I look at travel photos and post travel photos to Facebook. I will study art and post that so my friends can enjoy it. Some people need sort of touch and pressure, and so hugs, I think, are, for the people that you're close to, people who are living with you, make sure you touch them and hug them. Obviously, you can't do that to everybody, but I think coping is such an important thing, and just being able to cope in whatever way is useful to you. And I think those are major points. In terms of kids, I think I just wanted to say that kids in general do about as well as their parents do. So it's really important for parents to try to keep their anxiety under control, to manage their stress. If parents struggle, kids will struggle. Otherwise, kids are fairly resilient. In the beginning, it may have been tough for kids to figure out what was going on, and hopefully you were able to speak with your kids and, if you're a pediatrician, the kids that you see clinically about this. I can certainly send resources on how to talk to kids about coronavirus or COVID-19. I can send resources about, kind of what to expect from kids at this time. But, I think in general, just, be as calm and reassuring as you can without being dishonest. There are things we certainly don't know. There's a lot of uncertainty, but, you do want to, be calm, reassure your kids, occupy your kids, and then just maintain, routines for them, I think are major points. As a child psychiatrist, I have not seen kids struggle more than before. If anything, they're less stressed because they are typically out of school, and kids really enjoy being out of school, so major stressor is removed. And parents are usually keeping them fairly occupied, or kids are keeping themselves occupied. So I have not seen kids struggle more than usual, but those are major points I want to make. So, thank you.
Thank you, Dr. Rohit, for that very helpful suggestions and hints for all of us. And I was just thinking, I had a friend in England who got COVID-19 along with his wife, who is more sick physically with a lot of other health problems. They have two 12-year-old kids, and they were all not positive, so they had to stay away from them.
Yeah.
And apparently they coped very well, and they showed a lot of strength. And and actually it makes them stronger. Like they say, what doesn't break you make you stronger.
Yeah,
and,
exactly.
Really well spoken.
Yeah, and social support. I think, the kids are resilient, and having that social support is crucial.
You have no allergies, I guess, seasonally, and I can't go out and walk like you do. But yeah, smelling roses, smelling the tulips, and spring flowers is a helpful aromatherapy. Next, Mona, you want to go, or want to expand on with your expertise from clinical and substance abuse psychiatry practice in community?
So I was going to talk about two different things: telemedicine, how I'm doing that in the office, and how that's kind of changed the way we're doing things. We're used to kind of seeing people in person. And I know that a lot of people have been doing telemedicine in the past, a lot of psychiatry at least, because rural communities don't have psychiatrists. And so a lot of psychiatrists have been using telemedicine. However, I wasn't using it. I was very hesitant to use it, thinking that I kind of need to touch, feel, like, even though psychiatrists don't necessarily examine patients like you would think, chest, heart, all that. But I like to be able to kind of hold their hand and say, you're going to be okay. And so I was a little nervous when getting started. I started, maybe it was the second week of March is kind of when this crisis began, where it was kind of like there was hints towards everything's going to be shut down soon. And my husband, he happens to be a dentist, and he says he told me I was maximizing the situation, and I told him he was minimizing the situation. So we had a little argument, but I got into this groove of, I need to get my office running. How am I going to pay all my staff? How am I going to be able to help my team from home? Like, what am I going to do? So I came up with a system, which is kind of different, because I know a lot of people are working from home, but I still am working from the office. Just patients don't come to the office. So I still have, a lot of my team coming to the office, and they sit in individual rooms, and we see patients just like we are in Zoom right now. And we kind of have a system, so they have their appointments just like they were scheduled 3 months ago. Well, they're still scheduled. And after kind of reading on it and finding out that you can use, I was having a really hard time with some of these Zoom software or VC or Doxy, because they were crashing because everyone was using them at the same time. So we started using Zoom as well as FaceTime once the president told us we were allowed to use it, HIPAA and all that. So FaceTime's been actually really the best one to use. And most people surprisingly have iPhones. So that was really nice. And what I've noticed is, I was very nervous that we wouldn't have that personal feeling, but actually patients are isolated, and they're very happy to be able to talk to you. And it doesn't matter what type of medicine you're in, but to be able to touch base and say, we're here for you, really makes an impact, and like, I think both of the speakers before me were talking about how, having that social connection is important. Well, we represent a little part of that social connection as physicians. And so I think we have to, maybe we underestimate how much we mean to our patients, but we mean a lot. And I actually appreciated that I was able to call them, and, I'm seeing different aspects of their life. Like, one thing that you're noticing is the back of mine, and I have pictures of my family, and same thing when it comes with patients, to be able to discuss those things. These are things, they're dogs that they talked about when they walked in. Now I'm able to say, oh, show me your dog. It's kind of a different aspect of psychiatry. And it's kind of beautiful if you look at it that way. So you have to we have to be resilient, and we have to change the way we do things. And so telemedicine is kind of showing us a different side of our patients. and showing that we can do it, you know. And I think, you know, most of the people on this are from India and, you know, have practiced in kind of different situations and have had to adjust. And in India, the reason why Indian doctors are so well-rounded and so resilient even is because they've been able to, they had to do things that I was born here, raised here, and I went to medical school here, so I did it all like this. But you guys saw patients and saw diseases that I would never even I've never even heard of, you know? So I think that makes all of us very resilient. I got to see it through my parents, but, you know, so that's more about telemedicine. And the other thing that, and I'm talking about telemedicine because it's not just about psychiatrists, it's also about just physicians in general. Telemedicine is, you know, the billing aspect, and there's so many aspects to it. It's so scary. And I grew up in a family of physicians. My mother's a psychiatrist. My father was a gastroenterologist. Every single person in my family is a doctor, like many of your families. And all of them are practicing in different ways. So it's really interesting to be able to talk to each other. And I think that's super important. And that's great that Api is doing this, to be able to talk to each other and kind of compare notes, even about all these different stimulus packages and whatnot. We need to share this stuff, because if you're in private practice, you're kind of in a little bubble. So you don't get to talk to each other. So this type of stuff is fantastic. And the other thing I was supposed to talk about was substance use. And it's something that we do in our office. We have an intensive outpatient program and a partial hospitalization. If you know anything about the spectrum of care when it comes to substance use, there's residential treatments. Well, you can be hospitalized for detox, then you may go to a residential treatment, which may be anywhere from 30 to 90 days or even longer. And then there's intensive outpatients and partial hospitalizations, which are more on the outpatient basis. So in my practice, we have an intensive outpatient and partial hospitalization. So speaking from my experience, I've noticed, you know, we've had to switch from a group therapy, which was in person, to Zoom. And, you know, how is that going to work? And it was really interesting that patients are just happy to have that social connection. And so, you know, right now, I think they were saying that 50%, there's been a 50% increase in sales of alcohol since March, the third week of March. What that means is either people are stockpiling or people are drinking more, right? And people are sitting at home, and if you are at all, you know, social, you'll see that people are having virtual happy hours, and they're having, you know, they're trying to stay connected. And a lot of people who have trouble with alcohol and when isolated drink even further, this is like a dangerous time for relapse. So we have to be really kind of cognizant of that and have that discussion with people that maybe you wouldn't have had. And that's in every aspect of medicine. So, you know, internal medicine, in any type of medicine, actually, you want to have those discussions, especially because they're isolated. You know, are you drinking? Are you smoking? Are you, you know, is there an uptake in anything? Also, you have to look at comorbidities with vaping and tobacco and marijuana use, and, you know, just decreasing the immune function. Opiate dependence and increase in overdoses, also causing respiratory depression. So these are all happening at the same time. And I have patients who are EMTs, and they were telling me that more than COVID, they're getting calls about overdoses, they're getting calls about mental health. So it's really interesting that this is all happening at the same time, and it's kind of revealing underlying issues that are happening maybe even at home. And they're saying there's an increase in domestic abuse and increase in, you know, child abuse. So we have to kind of talk to people about these things. Alcohol, you know, when you're doing telemedicine, one thing to talk about, if there's an increase in alcohol and they're having a hard time cutting down, there's medication management for that. So talking about different medication management, I can go into that later if anyone wants. And then there's, you know, I do outpatient detox, so that's something that we can do. And, you know, and then there's therapists that are available that can do telepsychiatry, for teletherapy, psychotherapy for both substance use and, you know, anxiety, depression. I can keep going on, but there's AA and there's Smart Recovery that's also online that you can do. But anyways, if you have any questions, I'm here.
Thank you, Mona, for that quick talk on private practice psychiatry and substance abuse psychiatry. And I'll ask Dr. Rao, like you were saying, in Pennsylvania, we have a funny system. We have a state sells all the wines and whiskeys through Pennsylvania Liquor Control Board, and they closed it a long time back. So people are going across to Ohio to buy, and the Ohio governor also said, no, you cannot sell liquor to outsiders. So people are running out of alcohol, except beer. I guess beer you can buy somewhere. But anyway, that's an interesting anecdote there. Dr. Rao, Murli Rao, my good friend, he used to be in Pittsburgh. People from Pittsburgh still remember. Prabir was talking about you earlier. So please go ahead and give us some of your experience and your take on how to handle this situation in a hospital system. And you're also a director of the program. And for example, my daughter is a third year med student. She came home a month ago. She doesn't know what her rotations are going to be like. So give us an overview of it from an administrative point of view, what medical education is doing, as well as residency trainings are doing to address this issue. Thank you. Go ahead, please.
Thank you very much. I thank Dr. Suresh Reddy and Ravi Kohli, my good friends, who have put this together, and the wonderful platform of speakers who have done a wonderful job so far. I'll speak from perhaps three perspectives, okay? And my curiosity in this started when I was reading about the Spanish pandemic of 1918 and how it happened, and very similar scenario. And after the first wave, there was relaxation, then people immediately started gathering, enjoying, and it's the second wave that killed the most people. So we cannot take it as relaxing the current prohibitions be lifted, and we should be very careful during that period. And it also happened in the third wave. So usually if you follow the pattern, it's like 100 years pattern. It comes in a big wave form in the whole world. It has happened before. So I want to talk about the collection of papers. Since then, I started looking into any publication that had mental health issues discussed from various professional organizations to CL listservs and the NICE, WHO, various guidelines. Actually, I thought, my God, it's going all over the place. And next day, when I want to remember where I read that, I couldn't find, maybe here, maybe there. So I said, okay, let me save everything. So finally, I decided to publish the compilation. I'm not written anything other than the preface and putting it together to ebook form, and that's freely available for anybody. And that's one thing I had done. And being the chair of the Department of Psychiatry in the Trinity Health System, it's the third largest health system, they were looking up to us for how we are going to deal with this problem regarding the mental health issues. So we are making series of 2 to 3 minutes video clips. I made 2 of them, and I'll be asking other colleagues to do their perspective on this and post it to the physicians and other frontline workers. Now, from an administration point of view, this has been the hardest time. We have a call-in twice a week at 6 a.m. with all the chairs and the clinical leadership group and the CEO. So financially, we are draining off our resources so fast. Yesterday, I had to do the ugliest thing I ever did in my life. I never anticipated I'll be doing that. That was to call the faculty meeting impromptu and announce how all the non-clinical staff will be furloughed for next 3 months, and the other to save the money because the cash is burning so fast. As a system, third largest being Trinity's, it's $1 billion just in the month of March. So on one hand, I want to save my faculty, staff all together as it is. We were a growing department. And now I had to suddenly announce all these things and then ask the secretaries to take 1 day without pay. And as a hospital, we have seen a reduction, 75% of the inpatient surgeries, because Loyola is big on transplantation, elective surgeries. Those operation rooms are shut down, and a lot of advanced practice nurses, anesthesiologists, and that department is suffering a loss, and the money is not coming anymore. So the most active parts are obviously the ER and the ICU, and that's not that much of a income producing, because you cannot refuse any patient who's coming with the symptoms. So we had to clear up a lot of hospital rooms to keep ready for the oncoming onslaught. And in doing so, of course, the revenues went down. And then as a consequence, we had to do this. I don't know what kind of hospital remedy this administration is going to offer. I hope there'll be a big relief for hospital, because we cannot dismantle a system we have built up so beautifully and then for the sake of one disease. And there are rest of diseases still going on. I mean, we, as you have heard in the news, there's a disproportionate representation of minorities who are being affected. And among that, we should include the mentally ill. Actually, the last 3 patients I consulted in the hospital over the last, I was on call this Easter weekend, were schizophrenic homeless patients who now have COVID. So how do you help them understand the gravity of the situation and help them wear masks when they leave the hospital, when you cannot convince them to take their medications in the first place? These are big challenges, and it's now I'm going to be speaking more as a consultation liaison psychiatrist, very close to be the hospital, and I can't stay out of the hospital. I'll stay in the hospital. There are no more medical students, and a good point was made. What are they getting for learning? Really, that's a very good point. But on the other hand, we want to protect them, and all our clerkship curriculum, other than non-clinical, is being taught over the virtual methodologies or whatever, and all the lectures are being made on Camtasia and presented to them. So there are non-clinical activities are going full swung, and but the thing is that clinical rotations are really what they were waiting for has been held up, and many are quite upset about it. When it comes to residents, they have been the working horses, and as a chairman of the department, I have to protect my residents. I have to safeguard them. And on the other hand, there's a lot of expectation on them being mental health providers, who is helping with the frontline workers. So our department is fantastic. We are having twice a week faculty Zoom meetings, and our health psychologists and a couple of psychiatrists came up with a wonderful idea of preparing a roster of availability, like we made a calendar who is available. So there'll be one point of hotline call for anybody working frontline. Let it be a nurse, let it be a physician, let it be a resident, whoever is on the front line with the COVID patients, who after their shift, of course they can't talk during their shift. After the shift, if they want to speak with somebody, we are available. We have created the hotline, and also we have created a couple of support groups, one for residents, one for the clinical staff other than the residents. And my GME department at Loyola, as well as our department as a whole, has been quite proactive in trying to offer our services. Of course, ambulatory services is all done via telepsychiatry, telepsychology, whereas hospital services, we are trying to distance ourselves from the actual scene it was extremely difficult for the ER physicians and ICU physicians to understand in the beginning what happened to the CL team, why they are not coming in as they used to. So it took a while, about a week of telling them we are still there, we'll be supporting them through audio-visual devices, and now they all have iPads, they connect with the patient and our residents. So we'll try not to expose the residents to an extent possible, but if they have to absolutely go, they go fully covered, the best way possible. And it's very horrific when we see those patients' faces. They're gasping for breath, or they're being intubated, or they're already being intubated. And all you see is that help seeking eyes with no visitors, nobody except we seeing them on the video, and then the nurse holding up the iPad cameras to them. And it's really, really sad situation. And what do we see in terms of clinical presentations? Since we see almost like a later stages of COVID, and when they're brought in for respiratory distress for intubation, in addition to a lot of anxiety, you see the fear, there's panic in their face, plus they become extremely delirious. They become so delirious that our routine management of delirium, which used to be haloperidol, IV, IM, PO, whatever, it doesn't necessarily work. And also we cannot do that, because if you look at multiple drugs they are taking and look at the QTC, they already have QTC prolongation. So if you had to put aside haloperidol, what else do you have? You cannot give them anything else IV, and they cannot take PO, right? So we have resorted to, for last couple of patients who could not be even controlled with maximum amounts of Presidex, they're so agitated, they were tied down, they're in panic, they're frightened, and they didn't know, they're confused. So we had to start them on Depakote IV, and which seemed to work. Maybe if there's something you may want to remember if you see CL cases like we do.
Dr. Rao,
Then
we'll come back to you with the question answers. At that point, we can respond more.
yes.
So thank you.
Those are the perspective as a CL psychiatrist and what happens in the hospital.
Thank you, Dr. Rao, for your anguish. I can sense, because you are so dedicated to your team and your program, furloughing people during this time. I heard the other day Mayo lost $3 billion. Now you're telling Trinity is losing $1 billion, and there are many, many more things are going to turn down. And hopefully, Dr. Like Vaswara said, we have a resilient community, we have a resilient country. We'll bounce back stronger, hopefully, much stronger. And I'll go last. I won't take too much of your time, and I want to go on a little bit of an upbeat note at the end. And I'm a psychiatrist in community practice. I'm a director for an outpatient clinic. We have multiple locations in multiple counties, and most of our patients are Medicaid, medical assistance, or self-pay kind of patients. So we serve very underserved population in the rural Pittsburgh around areas. Probably Dr. Rao will know. When I say Waynesburg, Washington, Charleroi, Monessen, Union Town, nobody goes there. You can hardly find a psychiatrist there. So we provide services there. As far as telepsychiatry is concerned, we never did it except in penal systems. We used to serve a couple of counties in the county jails. So we used to, actually, they're the secure patients in a secure platforms, and figuratively and literally, we used to do consultations, psychiatry consultations to the inmates. And now we are implementing similar protocols across the nation, meeting people on online, on phone calls and video calls. So we deployed it very rapidly because our patients cannot wait for the system to ramp up. So we're able to go out, and like many of you said, a lot of patients are very appreciative of our reaching out to them. And surprisingly, some of them are much more resilient than I expected them to be. Some of the most sick people somehow seems to bounce back. They seem to have realized their problems are not as significant in view of the bigger picture. That's and when the whole world is suffering, sometimes you develop more empathy and you have less sensitivity to your own pain, it looks like to me. So some of them seems to be handling it very well. I'm very pleased to tell you that. And as far as, yeah, I'm doing all telepsychiatry myself, and I consult with inner city clinic once a week, and we are able to reach out to them through some platforms. I hear Zoom is not as secure as we would like it to be, and there are apparently 500,000 Zoom accounts are on sale in the dark web. So be watchful, careful. And so most people are migrating away from Zoom into more HIPAA compliant, relatively speaking, platforms, Doxy.me and those things. So what hasn't happened in 3-4 years, technology has ramped up in 1 month or even less than 1 month. So that's the positive about this situation. This crisis really created opportunities for entrepreneurs as well as scam artists, like Dr. Tarak Waswala said. There are a lot of scammers going on. A lot of fundraisers and scam phone calls are coming through. So be watchful, especially for your geriatric patients. Make sure they get calls from these Nigeria somewhere else. Make sure they don't reveal too much of their personal information. Everybody wants to be connected, so they're all vulnerable out there, and they're very naive sometimes and very easy to be exploited. So please help them to protect themselves through their families. I have some way in doing this video calls, and we're able to connect with families better than we did before of the patient. Before, patients used to come by themselves or with a limited family support. Now we're reaching out to where they live, where they um, stay. So we're able to connect with some family members that way, and they're appreciative. They feel connected to you now, and they're able to reach out to you. So those are the positives I see. And I also want to mention about spirituality and mental health. We all know spirituality as a Eastern heritage people. We know the value of spirituality, and Western civilization has kind of dichotomized between science and religion, or science and spirituality. But I think more and more in the last 10 to 20 years, there's more of merging of the minds and understanding of the Eastern philosophies. Even in the Western philosophy, the meditative, contemplative view of life and the world and existence and afterlife, these are all being looked at. And mindfulness and meditation, the breathing, the pranayama, yoga, are all getting very popular now. And people are benefiting from that. And there is clear evidence that mindfulness does help. And there is clear evidence spirituality does help patients' well being. And there are studies done. Some of them are anecdotal, some of them are quantitative, some of them are low kind of scientific basis, but still there's a consensus of evidence that spirituality does help mental health, not only in depression, anxiety, post-traumatic stress, even in people who are recovering from physical illnesses like cancer, heart disease. If they have a spiritual connection and rootedness, they seem to recover better than non-spiritually inclined people. And it helps their coping style. And people who are tend to be religious or spiritual tend to have a collaborative attitude rather than kind of totally autonomous kind of way of thinking and functioning. This collaborativeness actually helps them to recover from traumas and tribulation that you cannot handle by yourself. So that collaborative attitude in people who are spiritual tend to have them. And the locus of control being inside of you, you cannot change the external world, but what you do, how you react, can help you deal with the stress. It's not the pain itself, but the anticipation of the pain usually hurts us more. Mindfulness studies have shown actually the people who practice mindfulness, their perception of pain is higher, but their anticipation of pain is lower, and the recovery from their pain is much faster. So the pain will be always be there. What Buddha said, the pain is a natural part of the nature. Pain and suffering is not going to be eliminated ever. But how we deal with that pain, how we process that pain, how we go from that pain, how we move on is what makes us stronger. And there is post-traumatic stress, obviously, from trauma and disasters like this. There's also post-traumatic spiritual growth. People who recover from these traumas get stronger. And we develop a lot of empathy from this kind of situation. For example, 2 weeks back, 1 month back, who would have imagined this is we're going to face this, that our financial situation worsens so fast. And but I don't think I'm thinking about it, but I think you get stronger. You suffer something, you get stronger. Just like you build a muscle by breaking it down and then exercising and breaking it down and building it up. Even the psychic strength builds up. The more suffering you get, sometimes you get stronger, you get more empathy, and you get more compassion for other people's suffering. And we suffered in unimaginable ways in the last few weeks, not personally, but kind of vicariously knowing our friends are suffering, our physician friends are suffering, and struggling for their life and death, really puts things in a different perspective. What we took so granted, so kind of given, now we kind of question our values. But these are all good. These are all good questions, good reflections to kind of grow for ourselves. And I think we're all going to be better people from coming out of this crisis, and stronger people. And we probably can do the same with our patient. We can teach these strengths and values and resiliencies to recover from their traumas. I know trauma is a very significant aspect of a lot of our patients' childhoods and early adult lives. And somehow they get stuck there and they suffer, they abuse substances, they get alienated from society, they become homeless, they all kinds of negative ramification of trauma and suffering happen. But maybe we can grow from this trauma as a group of people and kind of bring those values to those people who acutely need those. So that's my small take on spirituality and practice of psychiatry in this crisis time. And I have a few questions. And Dr. Kiran Patil from Pittsburgh, I think, he asked us, how we have a platform to boost the morale of the, it would be the physicians as well as community. I would say this is what we're doing is part of building a platform to build up the morale of the physician. Whoever participated in our programs, I believe they are getting something out of it. They're connecting with a large group of physicians who they might have seen or heard or met briefly, but we are connecting as a group now. I think we can make this experience a really bonding experience and become a stronger organization, stronger union. And so I think that's part of it. I think Dr. Patil, I hope that answers your question. And then Dr. Aparna asked a question about registry for convalescent therapy, convalescent plasma. And we are not experts on that as mental health professionals, but as organizational people here, we're all working on some registries, but there are a lot of glitches, a lot of hiccups on that. If anybody wants to, is Dr. Suresh Reddy here, or if he wants to answer that question, Suresh?
Can you hear me?
Yeah.
So basically we are forming three teams, one team, because plasma is a little bit confusing and nobody knows, and it's still in the infancy stage basically. So we are having three separate teams. One team helps in getting the plasma donated and working with the donors and trying to get connecting with the families and connecting with the plasma collection agencies such as Red Cross. That's one committee. And the second committee is second hurdle we have is at the hospital level, where the administrators are resistant to giving it because of local protocols. So that's another team that's working with the administrators in the hospital. And the third one is at a higher level, the third team that's working with the government, the president, writing letters to the president, vice president, governors, senators, congressmen, and the health officials. So we have three different teams doing three different things, but we are working aggressively.
Yeah, thank you, Dr. Reddy. And actually, let me read a disclaimer before we were supposed to read this. The services of API COVID teleconference is for information purpose only and could not be and should not be considered as medical or financial advice. API has no liability as to how this is interpreted and has no liability for results, losses, or damages that may be caused directly or indirectly or incidentally. Please refer to CD website and your state government health authorities for CDC website and your state government health authority for more information and updates. That's a disclaimer we needed to read according to our legal counsel. So talking about how do we support primary care physicians who are serving in federally qualified health centers, psychiatric consultants. Somebody asked that question. Can anybody answer it? It's kind of a tough question because FQHCs are kind of in rural areas. They're already underserved. And I think maybe being a telepsychiatry program getting more available, probably we can connect better with FQHCs. But I think we need to connect better with different systems. Anybody else, anybody in the panel wants to address that question about consulting with the PCPs for providing some psychiatric support?
Well, I can tell you from my experience, even in Raleigh, which is a bigger city, I constantly am talking to the PCPs in the area. I'm big because I'm more referral based, I guess. So what I do is I give them my cell phone number. If I can't necessarily get them in, they can curbside me. And so that might be a way to kind of get them assistance. You know, if you can't really be everywhere at the same time, but you can actually help people out, especially right now. And not even just so much for patients, but for themselves. You know, they might be feeling a lot of the, you know, the things that Dr. Vasavada was saying. You know, he was saying that, you know, just the fears and all this stuff and bringing up a little bit of anxiety. And so maybe that would be a good thing to be able to say, okay, you're not alone, you know? So even having some of these type of things, these Zoom calls.
Yeah.
Right. Thank you.
Could I add something?
Please, Rohit, go ahead.
Sure. So I think what Dr. Gupta said is quite right. What Dr. Vasavada had pointed out was that we have a duty to care not only for our patients, but also for other doctors and allied health professionals. So, I mean, I know at work, my boss, who's a psychologist, asked a number of us to be involved in peer support groups, peers here being, you know, medical professionals who are struggling because of what they're going through. I work in a city, Chelsea in Massachusetts. That's the hardest hit percentage-wise of any city in Massachusetts, a higher rate of infection than even Manhattan in New York City in general. So the providers that we're working with, or the, you know, my primary care colleagues, pediatrics colleagues, are seeing very high rates of infection. We have a respiratory illness clinic, and that's seeing about 140 people a day. So we were asked to really do peer support groups. And, you know, I think DoxyMe, I believe, has some kind of physician hotlines. There are, and there are physician support groups out there. There are psychiatrists that are speaking to physicians, but I'll be involved in a group on grief, helping doctors deal with sort of illnesses, deal with people who have fallen sick and died and things like that. Another point that I wanted to make about just in general is, you know, I think what you're saying about community is very right, that we are building community here. I mean, this is somewhat altruistic, you know, we're trying to provide a community service. And that's what I think, you know, we can all try to do is you know, find a way to thrive in these times. We've certainly had to change and do things virtually, but, you know, but we can find creative ways. We can be creative. We can find ways to be altruistic. We can find ways to give to others, think of others, give to others. And build community. And I think that's, you know, that's really important. The New York Times had a good piece on altruism and how altruism in the era of coronavirus is one sort of pathway to finding meaning and overcoming this.
Yeah, let me introduce, I mean, Dr. Suresh Reddy, want to give a final comment. He had to leave for something else. Dr. Reddy, you want to take your vote of thanks for a minute? I don't know, maybe, yeah. Dr. Reddy, Suresh,
yeah, I'm here.
please
Thank you. Actually, I had to jump into the conference call. I just want to thank all the speakers, especially my good friend Tarak Basavada, and Dr. Murli Rao, and Dr. Ravi Kohli, and Dr. Bona Gupta, and Dr. Rohit Chandra. Thank you for joining, even though it was a late notice. You were able to join. Thank you again, and we'll do more sessions. Every Wednesday, we are trying to do a specialty session, and every Saturday, we are doing a team-oriented session. And this Saturday, it will be on the plasma donation and administration and the policies and protocols. Thank you very much. I have to jump into another meeting. Thank you again.
I actually want to thank Dr. Suresh Reddy for his leadership during this crisis. He has really gone beyond the call of duty to bring all of us together in a very short notice on the fly. And I really want to applaud his leadership. He's trying to make a difference, and we're all glad.
And also, I want to thank my co-pilot. She's here right now, Seema Arora. She has been extremely supportive. Thank you.
Yeah, thank you so much for giving us this opportunity to work with the rest of the community of physicians. And let's see. Actually, last few weeks, I was growing a beard. I wanted to call it Corona beard. I don't drink Corona beer, but I thought I'll have a Corona beard. But my vetoed it, so I had to shave it off today. Anyway, let me put a question to hospital people. How the hospital administrators can be up to speed? Dr. Rao, can you answer that question? With the COVID plasma therapy, it seems to be there are a lot of roadblocks, glitches. I don't know what your perception is, what your position is with how to convince. I think there's a lot of action going on. I know with things that can happen right away yesterday, but things don't happen that way. But please give us some perspective from administrative hospital point of view.
I think what I heard was that there is a big move being done by the CDC with the blood banks and the first aid to start collecting the plasma sample from numbers of centers, but the first aid to coordinate from various recovered COVID patients. I think that move is going on, and our CEO and the Trinity system are part of that, and it will come down sooner or later, trickle down to Loyola system, I believe.
Tarak, this question you might be able to answer. When you're doing inpatient hospital psychiatry as well as consultation, are you able to connect with the families and help them process either the anxiety or the grief or the isolation or quarantining or the recovery?
Actually,
yeah.
Not able to talk to patient as much. I'm talking to family more. Family is not there, but I call them, reach out, and doing a lot of things on telephone gives you more flexibility to answer your phone call quickly. And you will be joined into the conference. And giving you answer about what hospital is done, I put a file here earlier, what our hospital has done. A lot of senior leaders that has come forward. It's from variety places. Our people are getting a lot of food donations. So we are doing some cheerleading every morning. There are some kind of small prayer groups going on. Alabama being a very religious place, chaplains are giving messages to them. Hospital has printed T-shirts they will be allowed to wear to relax some of the codes for the particular dress codes. So I think it's interesting to see that so far we haven't seen any kind of worries that we had. Like people in Alabama are buying guns and stuff, but we don't see anything that is going on. That's the positive part of it. I think there is always a humor in these things that what people are spending. I mean, toilet tissues, it doesn't matter to me as an Indian. We have been always using my hand. I was 29 years old, so I don't know why it matters so much.
TMI, Dr. Vasavana, about his hygiene.
Yes, I know. We will survive. What I mean is that hospital has to come up with some ideas to cheerlead. I've left a file there. You can download that kind of thing and work with the hospital to create more things. And we will have our hotline coming up. Dr. Bupala here has helped me to reach out to a lot of primary, the therapists, and we'll be starting that soon. But luckily, Huntsville has not been hit, so maybe we don't need to use it.
So yeah, thank you. Dr. Gupta, you're probably seeing a lot of patients with ADHD complaints and prescribing stimulants. How is that working out with this more doing telepsychiatry and ADHD evaluations and treatments?
Can you hear me?
Yeah.
Okay. So I have a EMR, and on my EMR, I have an ability to send electronic prescriptions and stimulants included. So I've been doing the telemedicine and then just sending the prescriptions. But honestly, before this, maybe a month before this, I did not have that capability. So I've kind of reinvented the way I'm doing things. But if I wasn't able to do that, I would have sent them in the mail or had them come to the office, because I'm still in the office, and just meet us outside. But that's how we're doing. And we're still doing regular evaluations. We can even do testing. We do CNS vital signs, and sometimes, not all patients, and we can send that, they can do it at home. So that's also a capability.
Thank you.
Our patients are initially thought that they won't be seen. So a lot of people came to the hospital.
Yeah.
And then I'm finding it a little bit easier sometimes to get appointment, but some doctors are still hard and fast. They don't want to see new patients. I'm not sure why they don't want to see new patients, because we can do most of things. When I look at the telepsychiatry studies, every way you can look at it, every slice and dice you can look at it, patient's outcome, patient satisfaction, everything was equal to a regular care. Only one thing was not equal, with doctor's own satisfaction that I helped out this patient. So we need to learn it, and we are learning it very quickly. It's good.
Yeah, and Dr. Sanjay Gupta has a question about friends and close relatives and friends suffering and sometimes succumbing to this illness. The grief process, and Dr. Rao, can you answer some grief-related questions, the stages of grief, how we deal with it? And then maybe Dr. Vasavada can follow that with his, and Dr. Rohit also, from a child psychiatry perspective, how to deal with grief, anticipation of death, especially dying alone in the hospital. And please talk about it.
Yeah, it's a very good point. The anticipatory grief, unfortunately, is causing a lot of havocs. I'll give you a case example of a COVID positive tested patient, a 39-year-old young man who attempted to kill himself because he thought that was the end of his life. And when he became conscious after came to the emergency room, and then he woke up, he realized that he was not dead. Actually, he was breathing quite well, and he was not even in respiratory distress. And many times this thing that was bothering him was the anticipatory grief. I'm definitely going to die. Why do I have to suffer? I will end it before it ends me. That we see in some patients, but more so in the families who cannot visit when we talk to them over the phone, because most of the information we get about our patient in ICUs who are intubated is obviously from their patients, and there is only one visitor allowed, and that one visitor we try to meet. And so everywhere there is this panic of the fear and the anticipatory grief are the two most pronounced emotions. And I think what we do is support them and say we are all dealing in an unknown arena, and so we can only focus on what best we can do. So we can do better things with what we can control instead of worrying about what we cannot control. And like all of the speakers mentioned, maintaining a routine and doing their things. They're doing their best to tell them, appreciate what they're doing, and that's the best they could have done, so that they don't have that guilt. And and also to give them some statistics how the mortality and lethality is 1 to 3% at best. That's 97 are going to recover, and to give them some hope. I think whoever is in the leadership position should never give up the positive reinforcement among the people who are in distress. I think we should always take the positive side and try to hone it up for anybody who's coming to us.
I echo that sentiment, and at every meeting I've been a part of or led, I stress the need for empathy. We're all dealing with unknown, and we need to be empathetic with all our team members, not to be demanding and not to be asking for answers we don't have. And we know we want things done fast and quick, but billion-dollar corporations and amazingly successful and smart people from Ivy League working on this solution. Sometimes we in the community may not have the resources or the answers, but we can help. We can be the soldiers working as a team and working together. We can educate the people. A lot of misinformation is going out, so we need to inform the public as well as patients what is right and what is known, what is unknown, what is speculation. So that's my take. And Rohit, you want to talk anything about children, how they're dealing with anxiety, grief, and questions or fear? I think I have a neighbor who is an Australian. He has 4 boys. They're running around on my backyard, my front yard, in their bikes. I'm so happy to see that. They're resilient, and I think the parents can learn from them, and parents can reinforce that as well. But tell me what you feel.
I think the points I would make are that kids, so young kids, you probably have to figure out what they're thinking. I mean, if they're behaving differently, if they seem to be struggling, you want to kind of ask them what's on their mind. You want to try to guess what's on their mind, and figure out how to soothe them and calm them. They may have certain worries that they're not sharing with you, but are kind of cycling in their mind. They're worried that, their grandmother is going to die, and somebody else's grandmother passed away, and now they're worried their grandmother is going to die. And so trying to elicit what their concerns are, figure out what's frustrating them, and try to kind of alleviate that. So I think at one level it's kind of really listening to, it's kind of asking them what's going on, listening to them. The older ones, I think just being available to discuss what's on their mind. And they may be a little bit, they may share more readily, but, having honest conversations. Kids know when we are struggling. Kids know when we're being dishonest. If we're saying, yeah, I'm fine. What are you talking about? No, I'm good. But if you're really not doing well, kids recognize that and say, oh, dad is hiding something from me. Mom is hiding something from me. It must be really bad. So I would be transparent and say, you are struggling with this. This is tough. You don't know when you'll go back to work full time, or you don't know, when you're going to be able to go visit an elderly relative, or, when you're going to be able to hang out with neighbors again, when the kids are going to see their friends. So I think there's a lot of natural uncertainty, and you just have to convey that to your children, and to children in general, that, and just be honest with them. I mean, it probably doesn't help to expose them to too much news. I would minimize, exposure to anything too frightening. You have to know your child and what's developmentally appropriate for that child, and really just monitor their, social media use, monitor their screen time to make sure they're not being exposed to something that is just too overwhelming. You don't want them to see pictures of dead bodies being loaded into trucks. You don't want them to be thinking about, the morgue. I mean, you don't want them thinking about certain things. But past that, in terms of, managing their feelings, I would just try to elicit what they're feeling, guess at what they're feeling, ask them what's on their mind, and just, be available. I think that's really important.
Yeah, we usually always thought that disasters and terrible things happen in somewhat remote areas like Syria, someplace else, but never happens in our shores. But
Right.
Kind of shows we're such a small world, bad things can happen anywhere, anytime. But here is a practical question to Dr. Mona Gupta. Usually they do urine drug screen. Dr. Seema Arora has this question about treating substance abuse patients. How are you able to monitor substance abuse while prescribing controlled substance as well? I know I don't have any answer, but I hope you can tell us something. How?
So because I have the intensive outpatient, we actually had to come up with a solution because we're required to have a drug screen once a week. So we just pick a day. We don't let them know the day until a day or two before. And we say on Wednesday, you have to come and drop off a sample anytime between this time and this time. And they have to actually come into the facility to do that. So everyone in my office is wearing, so we don't have patients usually coming in except for this case, and some new patients are still coming in because they're from the hospital or whatnot, or hospital discharge patients. But anyways, they'll come in, they give their urine sample, and they leave. And this could happen. This could be a Suboxone patient, it could be a naltrexone patient, different people, but just random day, and we just let them know 1 to 2 days before.
Yeah, and there's one question here, Dr. Aparna, about telemedicine platforms. I myself have used Doxime. What I do is I came up with my own plan. I had a Doximity account and an app on my phone for a long time. I used the dialer, which hides your number, so caller ID won't reveal your number. You can put your office number and dial with the Doximity phone dialer, so they won't know you're calling from your cell phone. It comes from your office. And so I do call them on the Doximity dialer. And now Doximity also gave me the option to do Doximity video calls. It's free right now for some reason. And I use that also. And another thing is there's a Google Duo, which is a platform for both iPhone as well as Android. You can use the Google Duo to connect with Android phones through your iPhone as well. And anybody else has any question, any answers on what platforms, Microsoft Team or Doximity or Google Duo, Facebook, WhatsApp, what are you using? What do you find the most useful platform? And let's see, who can answer? Maybe Mona can answer and then Tarek can go ahead after her.
So, I'm using the same thing. I started with VC, but VC stopped taking new users, so then we had to stop that. So whichever patients have VSEE, they have that. But I've been using FaceTime since they kind of approved it for this catastrophe, like this time period. And then Zoom, but people are very nervous to use Zoom, like you said, because of the issues that they're having, and Doxime. So I've kind of had all the different options because I had to, because not everyone has an iPhone. But we've been doing between VC and FaceTime mainly.
Dr. Seema mentioned she's using Wavebee, FaceTime, WhatsApp. People can give their feedback on the chat, and I will read it to people as well as you can read it as well. And another question is,
Hello?
Anybody else want to give any other suggestions, comments? Tarek?
Yeah, we usually call on the phone, but sometimes I use the Skype business probably. If your organization is an account, you can use that also. There are some apps coming out now where I know my UAB colleagues use it, where you can just send the text to the patient, and once they open the text, the video opens from there. So it's very easy. But even that, patient cannot figure it out. This is like 70-year-old people, they have never used this smartphone well. And so, but a lot of patients are learning. Other day, I helped a patient to download the WhatsApp Messenger. So, the Facebook Messenger, so he can talk to his family. And he was very happy to do that.
My cousin, he's actually a pulmonologist, critical care in South Florida, and he has his own app. It's called Listen MD, and it's really interesting because he's been using it in the ICU. So he'll go and do his exam, but then he'll keep going in, or he can, the patient will have it on their phone and he has it from outside. So he'll even talk to patients that way, even in the hospital. So look up that too, Listen MD. It's free and it's an app on your phone. It's really good.
What is it called? Can you type it here?
Yeah, I'll write it.
I always like to use humor to kind of reach to people sometimes. What is everybody doing? Indian love Teen Pati and Rummy. How are you guys playing Rummy and Teen Pati? I have my friends asking that question. Anybody has a good suggestion on that?
I think we have been watching mostly comedies. Even the old comedies are good to watch at this time. They always always gives you pleasure. I mean, I know you like to watch this movie Contagion, but try to stay away from those kind of things too much. And like,
Exactly. I mean, you want to stay away from the television, the 24-hour news channels,
yes.
and use this time to enjoy the time that you have.
Yeah, small things. Yeah, small things. Open your closet and look at it, what you need to throw it out. You wonder why do you have collected so many things that has nothing to be, imagine that you are dead and your kids are walking around in the house and see what will they look at it and what will they throw it out first, maybe the inventory you should take of your life too. This is a good time to do that.
Absolutely.
Our perception of life and living has changed dramatically in unimaginable ways. I think we can declutter our lives as well as our closets right now. I think this is the best opportunity to do all that.
Yeah.
And actually, let me take a minute to share my website screen since Dr. Rohit Chandra mentioned. I feel it can be a valuable asset or resource. I use this as my kind of relaxation doing this site. So let me share that if you don't mind.
Ravi, meanwhile you do that, my nurse asked me, what will happen to us? And she was very worried. I said, well, only two things will happen. Either we come out dead or we come out poor. So your choice.
Nah, I feel like we'll come out strong and.
No, I'm just kidding with her. Then I gave my own pep talk. I just started with that. Sometimes you paint the worst scenario and you take it from there.
Very
and
funny.
Another thing I've noticed myself since I'm wearing mask, I've been using my hands so much. I was like, what am I doing? What am I talking to people like this?
Yeah. So let me share my screen here. Can you guys see this? So this is my website, ravikollimd.com. I just created 2-3 weeks back. And actually, if I remember right, Tarak, I mentioned to you, I was planning to release a letter to Hoppy one time 3 weeks ago about stress and coping with COVID. I didn't even realize what the magnitude of problem we're dealing with. But all the points I hit that in that letter seem to be relevant even to this point, to this day.
Wow.
And I use my energy in building up the site where I'm posting daily updates on various medical publications, and it goes all the way down to 323. And then I also posted some self-help videos. I hope they're not copyrighted, but they're available on the website. So I'm kind of posting them YouTube link. So here is the self-help videos. It may take a while to load. Some of them are related to yoga and some of them related to science of so ravikollimd.com, a lot of resources if you want to use them. And there are a lot of
I never clicked it, Ravi. I didn't realize it was right there. I just missed it probably.
Yeah.
I've been to your website several times.
And there are a lot of resources here, mental health resources, informational resources, general publication. So please check it out, and you might like it. And you can share your feedback, and I'll try to update my sites. And Dr. Murli Rao has some resources. I'll also post it on my site as well as API site. And Dr. Rohit gave us some resources. Anybody else has any questions? I think we answered pretty much everything. Dr. Trivedi, you have any question? Yeah, Dr. Trivedi, maybe Rohit, you can connect with Dr. Trivedi in Boston. He was looking for some kind of help on how to do telemedicine, telepsychiatry.
Ooh.
Can you help him?
Let's see, Trivedi. Let's see.
Trivedi.
I don't know that I know that much about telemedicine and telepsychiatry, to be honest.
Okay.
I mean, at this point, we've been doing phone visits, but I mean, the platforms Doxy.me or Doxy.me and the Microsoft Teams seem like they're quite good. I think the question is just, I mean, does he? Yeah, I mean, there's a lot to discuss about that. I don't know that I'm the best person, even though I'm in Boston, to discuss telemedicine. The Mona may be better about this.
Yeah. Even using a phone as a resource, we don't have to have a video call. Sometimes it's useful, sometimes it's not necessary.
Yeah.
I usually do a video call for all my first evaluation patients. Follow-ups, once I get to know them, I don't necessarily want the video call because of the privacy and other things that they want to, sometimes don't want to. So definitely I wanted a video conference call for the evaluations. And the people I already known and seen long time, I don't necessarily ask for a video call. All the new evals, I'm doing a video evaluations. So that's, I think we can finish. I don't see any other questions on the chat.
I think somebody asked, what's the best software for psychiatrists? But
Yeah, I don't know. I just got an email from my administrator. They're doing tele something, and
So I've used a couple of them. I've used, one that I've used was called Valent, one was called CarePaths, and one currently that I'm using is Advanced MD. Advanced MD is extremely expensive, so it's very good, but very expensive. Valent was decent, but I mean, I think all of these softwares, at least for me in private practice, they pull a dime, so you have to just be really careful when you're picking your software. The Valent was psychiatric specific, so Valent MD, and it was good. It was just nickel and diming, so I changed over to Advanced MD, and Advanced MD is extremely expensive, and they nickel and dime too. So ultimately, there is no perfect one, but Advanced MD, non-psychiatrists use it as well, so it kind of is like my office, I find it more to be a primary care type office, so I want to be able to communicate with all kinds of different physicians, so it's got a better
yeah, I think pretty much all systems are very similar. I think whatever you're comfortable, whatever you feel most. Some people want a lot of bells and whistles. Some people want simple interfaces. So it depends on your skill and your needs and your patient's need too. Some patients may not want complicated systems. So there's no one size fits all. So try a few things on a free service basis, and then get comfortable and use whatever you feel works best for you.
One thing I wanted to say, just because I noticed Dr. Aurora says there's a difference in reimbursement between video calls and audio. And all the things I've read recently, I'm on multiple forums, the audio calls right now, because of the crisis situation we're on, they're actually paying the same as the video calls. So you should look into that. Don't use I think you don't have, even Medicare is allowing you to use the 9x2 2.5 if you need to for the phone calls. So just look into that.
One general question, Dr. Gupta asked, how much the politicians are contributing to the stress. That's probably politicians are a part of us. Either we contribute to the solution or we contribute to the problem. And a lot of time they're more of a problem maker than solution maker. But we all can be in the same boat. We can be part of the solution or part of the problem. So we all.
Good one though are our New York governors. They're like very peaceful. I mean, he just keeps on talking and doesn't get too riled up. I mean, it's like Bob Ross. I mean, the painting, of the.
Yeah. So as far as spirituality is concerned, there is mindfulness-based stress reduction therapies. MBSR, John Kabat-Zinn. His book is a seminal book in 1990s that was written by him. Living. So there are a lot of resources. You can discover them on YouTube, various other platforms. Please use them if you have free time. Read about mindfulness, mindful stress reduction, and all the MBSR and all those things. And I think we did a good, I feel like we did a good job, 1 hour, 1.5 hour of conference. A lot of people attended. We still have 50 people, and a lot of people stayed back. And I really want to thank all of you, Dr. Rao, Dr. Vaswada, Dr. Chandra, and of course, Api and Dr. Vijay Kodali, and Lokesh Shidra, who initiated all these conferences, and rest of the leader, Dr. Janal Gada, Dr. Anupama. They're really the strong force behind all these activities. They don't necessarily ask for credit or take credit, but they really do a great job behind the scenes. I really want to applaud them for their leadership. And of course, our members are all rising to the occasion. They're all bringing a lot of questions to the fore, and they're focusing on a lot of problem that needs to be answered. I really applaud them for their passion, for their dedication, their love, for their friends and families. They want the best for everybody. So I really applaud all of you for your commitment to serve beyond yourself and your families. Really, hats off to you. Thank you.
Thank you. Bye. Good night.
Good night, everyone.
Thank you and good night.
Good night.
And Dr. Coley, I compiled a list of the resources that were mentioned on this call, and I just sent them to myself. What email address shall I send them to for you? Do you want to send them
at gmail.com is good.
What is it? Ravi Kohli at Gmail?
Gmail.
Sorry, say it again.
Ravi Kohli, MD at gmail.com.
Oh, okay, perfect. Okay, I'll email them now. Perfect. Thank you.
Once again, all of you.
Yeah,
Thanks, Ravi.
wonderful.
Be safe, all of you. Thank you.